My name is Amy Mottl. I am a nephrologist at the University of North Carolina at Chapel Hill. Been there for over 15 years. And my primary interest in research as well as clinically has been in diabetic kidney disease, partly because diabetes has impacted my family, as it does for many, because it's one of the most common comorbid diseases that we have in this country and even worldwide. But also because half of my patients, if not more than half of my patients, have diabetes and kidney disease. And one of the things that's really touched me personally about it as well is the fact that it's oftentimes populations who do not have access to care who end up with kidney disease. And so I feel like it's also partly a social issue, and I think it's particularly relevant these days. So much of my work has been in epidemiology and looking for novel therapies and diagnostics for kidney disease. We don't have a way to predict when a person is going to get kidney disease until they already have it. And oftentimes it's very advanced at the point that they're diagnosed. So if we had a marker or a test that we could do to tell our patients when they are at highest risk for kidney disease, I think that would really help us as practitioners in part know what are the best strategies for that patient. So for instance, now that we have GLP-1 agonists and SGLT2 inhibitors that are very good, especially the SGLT2 inhibitors at preventing and slowing the progression of kidney disease, I think it would help us to know what are the agents to use in that particular person. I think it also helps us to set goals of care in terms of blood pressure and glycemic control, because that can be very difficult. Do we use an A1C less than 8, or should we really try and get them below 7? Same thing with blood pressure, and it varies in terms of an individual's risk for macrovascular complications. So I think if we knew ahead of time that somebody was at very high risk, we would probably set those thresholds lower. I think it's also very important to the patient in terms of motivating the patient. If we tell an individual that, they're at risk of kidney disease because they have diabetes and their sugars are uncontrolled and they're overweight, there's always the, oh, it won't happen to me mentality, which is just a human reaction to, any risk. However, if we can say, well, we have this test like PromarkerD that tells us that you probably are going to get this disease unless we do something dramatic to change your risk. And I think that potentially is very helpful, because I see that when patients come to me and they already have kidney disease, suddenly they're very motivated. Sometimes they come to me when the horse is out of the barn and it's harder to impact a change in terms of the trajectory of their clinical disease. So to do that earlier would be much more efficacious. There have been studies looking at the cost of care for a patient with diabetes without kidney disease versus, more advanced kidney disease. So stage 4, certainly stage 5, the cost goes up dramatically. And not just because of their care for their kidney disease, but actually it's more related to their cardiovascular disease that goes hand in hand with the progression of their kidney disease. The cost of heart failure and MIs and strokes, all of which are in part due to kidney disease. And the worse the kidney disease, we know, the worse the cardiovascular events. So some of these studies have shown that there's a 10 to 20-fold increased cost to care for those more advanced CKD. And this is not on dialysis. This is, stage 4 and 5 prior to the need of dialysis versus the diabetic patient with no kidney disease. So I think the cost would be quite substantial for this country. It would go back to, knowing what sorts of thresholds to set for a patient in terms of their glycemic control and blood pressure, because if somebody has exceedingly high blood pressure or A1Cs, then our work is cut out for us. But it's in the moderately well-controlled people that were left in a quandary. So the patient whose blood pressures are in the 130s systolic or has an A1C of 7.8, Do we add on therapy? Do we increase medication doses? I think that would be a place I would certainly consider it, as well as people who have microalbuminuria. You know, historically, microalbuminuria was thought to be this fantastic marker of progressive kidney disease, and the natural history of diabetic kidney disease has just remarkably changed over the last 20 years. And we know that it can wax and wane, can even completely vanish in some people. So it's hard to know what to make of that. And so I think if somebody has microalbuminuria, then to know whether those are the people who are likely to progress on would also be helpful.